Many patients come to the clinic and say, "Doctor, I need an MRI." But there is an important truth. MRI is a powerful tool, but it's not the whole diagnosis. An MRI can show the meniscus, ligaments, cartilage, bone bruising, swelling, and many soft injuries. But the MRI must always be connected with your symptoms, your physical examination, and your injury history together with your functional limitations. Because we do not treat the MRI picture, we treat the patient. I'm Dr. Tomislav, orthopedic surgeon specializing in sport injuries and knee surgery. In sports medicine, MRI is one of the most useful investigations we have, especially for the knee injuries. It helps us see structures that are not visible on normal X-rays, like meniscus, ACL, PCL, cartilage, tendons, and bone marrow changes. In sports medicine, MRI is one of the most useful investigations we have, especially for the knee injuries. It helps us see structures that are not visible on normal X-rays, like meniscus, ACL, PCL, cartilage, tendons, and bone marrow changes. But MRI should be used at the right time for the right patient and for the right clinical question. For example, is there a meniscus tear? Is the ACL ruptured? Is there a cartilage damage? Is there a bone bruise after trauma? Is there an injury that may need surgery? This is where MRI becomes very valuable. If someone has knee pain, we do not automatically start with MRI. First, we listen to the story. Did the pain started after a twist? Was there a pop? Did the knee swell quickly? Can the patient walk? Is the knee locking? Is there instability? Is the pain gradual or did it happen suddenly? Then we examine the knee. We check movement, swelling, joint line tenderness, ligament stability, meniscus signs, muscle control, and walking pattern. In many cases, an X-ray is also useful, especially if there was trauma, chronic pain, suspected arthritis, some deformity, or concerns about the bone injury. X-ray doesn't show a meniscus tear, but it can show bone alignment, arthritis, fractures, joint space narrowing, and other causes of pain. So MRI is excellent, but it's not always the first test. MRI is especially useful because it shows soft tissues. In the knee, MRI can help evaluate the meniscus for tear, displaced fragments, root tears, or complex degenerative tears. The ACL and other ligaments, especially after twisting injuries, instability, or sports trauma. The cartilage to check for the cartilage defects or wear. The bone marrow for bone bruising, stress reactions, or hidden fractures that may not be clear on X-rays. The tendon and muscles, especially after overload, rupture, or sports injuries. And also swelling inside the knee, cysts, inflammation, and post-surgical changes. For meniscus injuries, MRI is one of the best imaging tools because the meniscus is a cartilage-like soft tissue and it doesn't appear properly on a normal X-ray. This is why MRI can be very helpful when the patient has locking, catching, persistent swelling, pain with twisting, or symptoms that do not improve with the proper treatment. But this is where patients need to be careful. Sometimes MRI shows changes that are not actually causing the pain. For example, a patient may have a small degenerative meniscus tear on MRI, but the real pain may be coming from arthritis, overload, poor muscle control, or a cartilage wear. Also, some MRI findings can be age-related or incidental. This means they are visible on the scan, but they may not be main reason for the symptoms. That's why the most important question is not only what does the MRI show? The better question is, does the MRI finding match the patient's pain, examination, and function? If the answer is yes, MRI can guide treatment very well. If the answer is no, treating only the MRI result may lead to the wrong decision. MRI becomes very important when the result may change the next step. For example, if we suspect an ACL tear in an athlete, if the knee is locked and displaced meniscus tear is possible, if pain continues despite proper physiotherapy, if there is a swelling after trauma, or if we suspect cartilage damage, bone bruising, stress injury, or a hidden fracture. Or in some cases when we are planning surgery and need to understand the exact tear pattern. In these situations, MRI is not just an extra information. It can help us choose between the physiotherapy, injections, activity modifications, surgery, or a structured return to sport plan. So remember, MRI is one of the most powerful tools in the modern orthopedics, but MRI alone does not decide the treatment. The correct approach is: first, listen to the patient. Second is examine the knee. Third, use X-rays and MRI when needed. And finally, match the imaging with the real symptoms and functional goals. Because the best treatment is not based on one image, it is based on a full clinical picture. So if you have the knee pain, swelling, locking, or instability, get a proper orthopedic assessment before deciding that you need an MRI or before deciding that you need a surgery.